Thank you, Anne, and to the organizers of this conference for inviting UNAIDS to be part of this process, which is a very important process because we know that we've made a lot of progress. Just the recently released report, as the former speaker was speaking, we have huge reductions of HIV infection. But we also have a long way to get to zero. To get to zero HIV infection, to get to zero HIV deaths or AIDS-related deaths, and to get to zero stigma and discrimination. And especially that last one, because I believe that unless we address stigma and discrimination, we will not be able to achieve the first two. Because most people will not even get tested because they are so afraid of knowing their status because of HIV stigma. And then they won't even go for treatment so that we can prevent deaths. So unless we address stigma and discrimination, we'll be very slow in getting to zero HIV infection and the others. We know today that it's possible to reduce, to eliminate HIV infection from mother to child. We are not doing as better as we should because of stigma and discrimination. Therefore, this conference is very important, and I want to congratulate Howard University for holding such a very important conversation. And I just want to say that UNAIDS is very pleased to be part of this, so I bring greetings from UNAIDS. For those who don't know what UNAIDS is the UN agency that brings together all UN agencies that work on development, on health, on economics, on family planning, on many other areas of the world, together to work on HIV and AIDS. And we work with governments throughout the world to help them develop national programs so that they can be able to respond to HIV and AIDS effectively. This is done by doing collaborative work not only with governments, but also with civil society organizations, also with the women's movement, with the law enforcement in the country, with teachers, with sex workers, with men who have sex with men, with people who inject drugs, and especially people living with HIV and AIDS. Because we believe that people living with HIV are not a burden. And I think that's one thing that we have to remind ourselves, that people living with HIV are not a burden. They are a solution to the AIDS epidemic. And the way we are going to do that is by removing our own stigma towards them, working towards addressing our community, and especially the religious community. You know, I come from a religious background. I come from Kenya, and I know what damage some cultural and religious norms have done towards people living with HIV, towards people who inject drugs, towards men who have sex with men, and towards sex workers. That has created havoc in many countries. My own country, Kenya, my own cousin died, not because of the AIDS epidemic, but he died because of shame. He died because he was so stigmatized by his own family. He died because at one point he couldn't even eat because his own family could not bring food to him. That's what killed him. It's not the disease itself. He could have gotten treatment from the health services in Kenya and he could still be alive. So when I talk about stigma, it's very personal to me. And I've also come to know many friends and relatives, women living with HIV who are so stigmatized. And the first thing they tell you about is their fear of living in stigma, not their fear of taking the medicine. You know, it's the fear of what their families are going to say, what their job, you know, some have even lost their work because of HIV, because of stigma and discrimination. So UNAIDS has the mandate from the UN Charter on Human Rights, which was created in 1945. And based on that charter, all human rights are supposed to be protected. It doesn't matter your skin color, your age, your ethnic background, your sexual orientation, your line of work, your human rights are protected and safeguarded in the Charter on Human Rights, created in 1945. So even today, everybody living with HIV, their human rights are protected under the Charter on Human Rights. So UNAIDS work very closely with governments, reminding them that they've signed, they are signatories to this charter. In countries where human rights are being violated, where they're coming up with laws, for example, to discriminate and criminalize men who are having sex with men. You know, I come from a region where it's illegal and you can actually go to jail. And we even have countries that are saying they will put you to death, you know, or life sentence if you are a man who has sex with a man. You know, so we remind them that the human rights of everybody are enshrined in the Universal Declaration of Human Rights. It doesn't matter what they do. And therefore, if they're signatory to that, they need to respect that. The same thing with women living with HIV. A lot of countries have a problem when a woman living with HIV becomes pregnant. You know, the first thing they say is you have to abort the child. Why did you become pregnant and you know you are HIV? You know, it's like when a woman gets HIV infection, she is supposed to become asexual. She's supposed to forget everything about the way God has created her as a sexual being. And some countries, including some that I don't want to mention, but actually if you go to UNAIDS website, you can see they have actually even sterilized women living with HIV without consulting with them. Women living with HIV have a right to get pregnant if they want to get pregnant. They have a right to access family planning services to prevent pregnancies if they want to do it. They have a right, to exercise their own humanity. They have a right to housing, they have a right to shelter, and definitely they have a right to safety, to security. I've come to work with the DC Community Coalition on AIDS. It's a group that was formed here 2 years ago for the International AIDS Conference. And through that group, I have come to understand the kind of stigma that exists here in Washington, D.C. Not in Africa, where I come from, but right here in Washington, D.C., where some of the people living with HIV can't even access housing. They can't even, you know, get, like free needles, you know, if there are people who inject drugs. They can't access all the information they need, and access to condoms, access to female condoms. Right now, you know, I'm so excited about the program on female condoms that's happening in Washington, D.C., because we have a right, you know, everybody to have safe sex, and the only way to do it is by abandoning stigma. UNAIDS has a small office here in Washington, D.C. That office works with the U.S. government, but we also work with civil society organizations, the private sector, universities, or research institutions, mainly to mobilize the political will, to mobilize resources to be able to respond to the AIDS epidemic. And I'm here today because of that little office here in Washington, D.C. According to UNAIDS, the protection of human rights is essential to safeguard human dignity in the context of HIV, to ensure an effective right-based response to HIV and AIDS. How are we going to do that if we don't have programs that specifically educate people living with HIV to know their human rights, to know the laws that exist in their country so that they can appeal to those laws to protect them? How are we going to do it if we do not empower the marginalized in our communities, like men who have sex with men, to know their rights so that they can fight for themselves? How are we going to manage it if we do not train health workers, if we do not train law enforcement officers, judges, and others who make policies in our countries that decides how people are treated? The only way to do that is by having very specific programs that address them, and more importantly also having community level mobilization efforts to stop stigma. Unless we stop stigma, we are not going to get to zero HIV prevention, we are not going to get to HIV AIDS related death zero, and we are not going to get to zero stigma and discrimination. The only way to do that is to remove our shades. And you can sit here and I can sit here and say, oh, I don't discriminate against someone. But if you are silent, when stigma is going on, you are participating in it. If you are silent, if people are being violated, if the human rights of women, if the human rights of people who have, men who have sex with men, people who inject drugs, you know, sex workers, if you are silent, you are part of that. And the only way to stop is to let our voices heard in this World AIDS Day. Happy World AIDS Day.
Thank you, Pauline, for lighting a fire under all of us, I think, and also keeping us very uplifted in this afternoon plenary. So thanks a lot. I'd like to introduce the next speaker now, Dr. Laura Nyblade, who is a friend and colleague for many, many years. We've been working together on stigma and discrimination reduction programs, and she's now with RTI and with the Health Policy Project as a senior technical advisor for stigma and discrimination.
Are you awake? You should be after that rousing call to action. Thank you for being here, and I want to thank Howard and Dr. Rana and Dr. Vargas Jackson for this opportunity and for continuing to have this event every year. It really is an amazing event, and I want to thank you for all the work and your team. I know this was done by a team of people and your dedication to put this on, because we really do not yet have enough attention on this issue. I'm going to speak specifically about healthcare services because that's what I've been asked to speak about, and it's also from where I come from. This is what we focus on, and I think a lot of what I talk about here is also relevant to other areas. So I'm going to talk a little bit about this presentation. I'll try to make it quick because I know we're a bit behind. I'm going to talk about who we are, the Health Policy Project where I come from, and then about stigma in health facilities. I know we've heard a lot about this, so I'll go through quickly some of the background slides and more focus on what we know can be done, what can be practically done to actually reduce stigma and discrimination in health facilities. And then talk about what we can do as a community to really advocate for stigma-free health facilities around the globe. So I come from the Health Policy Project, which is a 5-year cooperative agreement funded by USAID. And we work around the globe, and our overall goal is to strengthen developing country national and subnational policy, advocacy, governance for strategic, equitable, and sustainable health programming. And we have multiple cross-cutting themes in our work, and stigma and discrimination is one of them. And we believe that to get to equitable health programming, we must address stigma and discrimination in its many forms. And so that's why we work on this issue. We also work on it because HIV is one of our key areas that we focus on, and I think as we've talked about this a lot, and our previous speaker said, we've made a lot of progress in the past decade, but if you look at this slide from UNAIDS, you see that we're kind of trugging along there with new infections. It's kind of a sort of a straight line there, and you see the blue dot there, that's where the global target is for 2015. Now to get to that target, we're going to have to severely push that line so it's actually going much further down. And how do we get there? And we really believe that we can't do business as usual, and that addressing stigma and discrimination is really how we're going to get to that target and really change what's going on. So we really need to speed up our work in decreasing new infections. So that's why we work on stigma and discrimination, among other reasons. What we've been doing to date is really working on strengthening the base for evidence-based advocacy and programmatic action. As we've talked about here today, and as we know globally, there's a real need to address stigma and discrimination, yet we do not have the concerted action and the scaled-up action that is needed and that you would think, given the stated need to do this. There's this gap between the stated need and action. So there's multiple reasons why that might be happening. One of them is that we need to bring together our evidence base to make our case more strongly. So that's part of what we do. And part of doing that is supporting the Stigma Action Network, which I hope you'll all join. There's flyers and some bookmarks left. They'll be up here if you want to join them, and I'll talk a little bit more about that later. We've been working to model the impact of stigma on prevention of mother-to-child transmission, to show the potential impact that we could have if we actually put more resources behind reducing stigma. In terms of that's just one program, we're looking at others. Looking at reporting and redress systems. So, for example, in Ghana, we're working with the Commission for Human Rights and Administrative Justice to look at setting up an actual reporting system for stigma and discrimination, where people living with HIV or people who are members of key populations can report discrimination and stigma that's happening, and then there's a redress system then for trying to address that discrimination. As we've heard today, addressing the layered stigma towards key populations, whether it's men who have sex with men, when it's people who are using drugs, whether it's immigrants, is really important. HIV stigma is layered on all of these other stigmas, and so that's part of what we've been doing, largely working in the Caribbean. And then as the Health Policy Project, we focus on healthcare systems. And so I'm going to talk a little, that's where I'm going to focus my discussion today and talk a bit about some of the practical things that we can do in the healthcare system to lead to stigma reduction. So that's what I'm going to do. And I think this quote really demonstrates, we all know how it manifests in healthcare systems. Sometimes it's very subtle, sometimes it's very overt. But as this woman in India says, she explains how stigma is manifesting in a way for sex workers in her community, where they go to the healthcare system, they get put to the back of the line, they end up waiting all day, and then they're told, oh, it's too late, we're closing the facility, and so no care for you. So this is one of the ways in which stigma manifests in healthcare settings. As I said, it can be overt, from denial of care to this sort of subtle way of just pushing people off. We've had instances where care has been made conditional on having an HIV test or using family planning. It can be premature discharge from a facility, or it can be compulsory or forced treatment. So it takes many different forms. So part of what we need to do in reducing stigma and discrimination in healthcare facilities is really starting to name it, to say this is what it is, this is what it is, because oftentimes we don't realize what we're doing is actually stigmatizing. So a big part of how you start reducing stigma is actually naming it very specifically. Again, I just want to keep reiterating, which we've talked about today, it's not just addressing HIV-related stigma, it's addressing all of the intersecting, layered, compounded stigmas that we face, and that in health facilities in particular, it's really critical that we understand this and that we address this, all of these stigmas together. So now I'm going to present a framework that we developed, modification off a global framework for measurement, to look at what are the areas we need to focus on when we're actually looking to programs to reduce stigma in healthcare facilities. And this is a little bit of a busy slide. I don't want you to focus on the details of it, but just to say, if you start on the left, there's actually what we consider actionable drivers. What are the things that you need to address in your programs that will actually start changing stigma and discrimination, that will lead to reduced stigma manifestations of different kinds, of anticipated, experienced, self-stigma, that will lead to the improved outcomes and improved impacts that we all desire. And to say that there are things that need to be done at the individual level with health facility staff, but then also importantly at the institutional level. So you need to think about the system of the individuals as well as the environment in which they work, and that there are things that need to be done at that institutional level. So I'm going to now just show you a slide that focuses just on that left side. I wanted to sort of show you this to show kind of that connection. There's things that drive the stigma and discrimination in healthcare facilities, and if we can reduce that in all its different forms, we will get the improved health outcomes and impacts that we are looking for. So if we look just at the left side at the individual facility level, we know from work around the globe, both within health facilities but also in our communities and within ourselves as individuals, that there's kind of three key drivers of stigma and discrimination. One is a lack of awareness and understanding of what it is. So when I gossip about someone, that is stigmatizing. I might not recognize that, but it has a very negative effect. So the simple act of helping people recognize and understand what stigma actually looks like in our daily lives and what it does can have a very powerful effect in actually reducing our stigmatizing behaviors. The second, which has been talked about a lot today, is the whole issue of social judgment and our prejudices and stereotypes. We need to address these head on. I know that it's often difficult to talk about these issues, but there are a lot of tools for doing that. We have to start talking about it. And then lastly, which has also been discussed, the fear of HIV infection. You'd be surprised 30 years into this epidemic how many people, including health providers, still fear that they can contract HIV through casual contact with people living with HIV. So we need to address that directly. We need to understand what it is people fear and address that in a way that they can really believe that it's not possible. So these are kind of three things at the individual level that programs need to focus on in the healthcare facility, but also in other areas. At the institutional level, we need to create an environment that supports health providers and other staff working in health facilities to provide stigma-free services. Some of the things that drive a hostile environment is a lack of policies and guidelines, inadequate training. If you haven't done the individual level training that helps people understand what's going on. The physical environment, are health providers able to protect themselves? And then adequate supervision and support. So to say that to really address stigma in the healthcare facility, you need to be looking at these two different levels, and there are good tools available to do this. And now I'm going to show you an example from Vietnam where they actually put all of these things together and very successfully reduced stigma and discrimination in their healthcare facility. And this study and the program is available on the website, and if you go to the Stigma Action Network, you can find it. But at the staff level, they had participatory training, and it wasn't just for medically trained health providers, it was for all staff in the health facility, because we know that often the stigmatizing environment starts at the gate or at the receptionist. So this group worked on training everyone, and they did it through a 2.5-day training that was broken into 2-hour sections so that they didn't interrupt the provision of care, and it was done over 6 months. So that allows it to be integrated easily into a busy facility schedule for delivering, not interrupt delivery of care. I also provided educational materials. At the institutional level, there was a lot of work to build partnerships with the hospital gatekeepers, very important. Data was very important in helping to demonstrate that there actually was a challenge and an issue. You go into a lot of health facilities and say, well, we don't have an issue here with stigma and discrimination, often because we don't recognize that that's what's there. And then structural changes that supported, in this case it was universal precautions were not being applied universally. They were being applied selectively. So gloves were being used with certain patients, or double gloves were being used, which then indicated to everyone else in the facility that this was a person living with HIV. So focusing on that. And then really importantly, the staff worked with the administration to develop their own code of conduct for their facility. So after having this awareness, then actually committing to a policy and a code of conduct that they were going to abide by, which was then actually put up on posters all over the facilities so that people knew this is what our staff has agreed to and pledged to. So that's just to give you an idea of how you can take that framework and actually apply it within a facility. Lots of tools that are available. These are all available on the Stigma Action Network, the ones that are already published. I'm happy to talk more about that. The other thing that's really important is measuring stigma in health facilities. This is a way both to advocate for change, but then also to demonstrate that programs are working. I'm not going to spend a lot of time on this because I know everyone's tired and time is running out, but just to say that there is a global effort that is going on to develop a global set of measurement for health facilities. We're in the process. We have 6 pilot testing sites, and we're hoping there'll be a few more, including perhaps Howard and DC. And we have three sites that have already finished data collection, 3 more that are in the process, and we hope to have a shortened tool ready by May that will be available for anyone to use. It's going to be submitted to the UNAIDS global indicator process for review and hopefully approval, so it'll be available as sort of a globally stamped tool. So that's available. I won't, there are multiple sections to the questionnaire that we're testing. It's going to become much shorter through the process of this testing. The key areas that we're measuring reflect some of the things I talked about in the framework, infection control and fear of casual transmission, the health facility environment, the policies and the work environment, and then again, the opinions and attitudes about people living with HIV and key populations. There's also a module that focuses on health providers who are working with pregnant women that asks a different set of questions around that. So this is going to be available for use. So just to say, it's time to change things. There's no excuses left for having health services that are not stigma-free. We know what to do. We know it's critical to do it. We have the tools to do it. We have the tools to measure our progress. So we don't have any more excuses about it. So just to say, what can we do as a group? We can, advocate for having health facility policies, keep advocating and monitoring and tracking what's going on in facilities. If we can link that to a redress system, that's helpful. As health workers, we can support each other to be a voice of change for policies that impact ability to deliver services, and then to really work on incorporating stigma reduction into pre- and in-service training for all health staff. Let's make it part of our medical school curriculum. Let's make it part of all training. It's not something special. It's something that's very integral to delivering quality healthcare services. Supportive policy environment is critical. National strategies with specific stigma reduction goals are really critical. Here in the U.S., we have a national strategy. It does mention stigma and discrimination, and that's wonderful. There is no specific target or goal mentioned in that strategy, and we know from our work around the globe that if you don't have an actual goal or a target, it often doesn't get the resources or attention that's needed, so it's something we need to advocate for. Thailand is one of the first countries to actually put an actual stigma reduction goal into their national strategy. So they're part of the way there. They are working now on how to actually operationalize that. So just to say that there are things we need to do both at the individual and policy environment level. And then you can join with the Stigma Action Network, as I talked about before. The website is there. We have flyers. It's a really good resource. All of the tools that I've talked about are on this website. It brings together experiences from around the globe. Yesterday, the PEPFAR blueprints, and so we work globally. PEPFAR, the President's Emergency Plan for AIDS Relief, is a really critical funding mechanism from the U.S. government, and they released a blueprint for creating an AIDS-free generation yesterday, and so I wanted to leave us with something that was actually in that document. It was really good to see that stigma reduction made it into that document in multiple places. But to say, again, that key populations are incredibly, they experience a lot of stigma and discrimination, and without addressing that, we are not going to get to the goal of an AIDS-free generation. Thank you.